Today, a priority review designation in cervical cancer, an ODAC recommendation in acute lymphoblastic leukemia, a clinical hold in cervical and head and neck cancer, and in addition to the NCCN Prostate Cancer Guidelines. Welcome to Enclave News Network. I'm Gina Columbus. The FDA has granted a priority review to a supplemental biologics license application for pembrolizumab for the treatment of advanced cervical cancer with disease progression on or after chemotherapy. This is the first time the FDA has given a priority review to an anti-PD-1 therapy in this disease. Merck, the developer of pembrolizumab, filed the application based on results from the Phase 2 KEYNOTE-158 trial. The ongoing global open-label, non-randomized, multi-cohort, multi-center study is evaluating pembrolizumab in patients with multiple types of advanced solid tumors who have progressed on standard therapy. Preliminary data showed that the objective response rate was 12% among the first 82 patients in the advanced cervical squamous cell cancer cohort, with 3 complete responses and 7 partial responses. All 10 responses were ongoing at the data cutoff. 17 patients had stable disease and 44 had progressive disease. The ORR was 14% among 71 patients with PD-L1 positive tumors, with 3 complete responses and 7 partial responses. None of the 9 PD-L1 negative patients responded to treatment. Under the Prescription Drug User Fee Act, the FDA must decide on the approval on or before June 28, 2018. In acute lymphoblastic leukemia, blinatumomab received an 8-4 vote from the FDA's Oncologic Drugs Advisory Committee in favor of an indication for the treatment of minimal residual disease positive B-cell precursor disease. The FDA will now make its final decision on the blinatumomab indication with an action date set under the Prescription Drug User Fee Act of March 29, 2018. At the meeting, ODAC sought to determine whether more than 0.1% MRD was a valid cutoff describing a subpopulation of patients with ALL in complete remission who have a need for preemptive therapy. Following that, ODAC voted to determine whether, in the greater than 0.1% MRD positive population, the benefits of blinatumomab outweighed the risks. Data were submitted from the Phase 2 BLAST study. BLAST was a single-arm trial of up to 4 cycles of blinatumomab for treatment of patients with B-cell precursor ALL in complete remission or CR with partial platelet recovery and MRD greater than 0.1%. Of 116 patients who received at least 1 dose of blinatumomab, the FDA identified 87 in CR with hematologic recovery and baseline MRD of more than 0.1%, including 61 patients in CR1, 25 in CR2, and 1 in CR3. 69 patients achieved a complete MRD response within the first cycle. Although the panel voted to recommend approval, there was no consensus on the appropriate MRD cutoff for treatment intervention. The FDA has put a clinical hold on a Phase 1-2 study of axelimagene filolisbac, also known as Axel, plus durvalumab for the treatment of patients with advanced, recurrent, or refractory HPV-associated cervical cancer and HPV-associated head and neck squamous cell carcinoma. Axel is a targeted Listeria mitocytogenes-based immunotherapy that attacks HPV-associated cancers. The FDA cited a safety report regarding a patient who died February 27, 2018, of respiratory failure following the 6th combination cycle in the trial. Preliminary results from the Phase 1-2 trial put on hold included 11 patients enrolled in Phase 1 of the 2-stage study at the time of presentation. 1 patient with cervical cancer achieved a complete response, which remained ongoing after 12 months of follow-up. Another patient with cervical cancer achieved a partial response with subsequent disease progression. Additionally, 2 patients with HNSCC had stable disease. Treatment-related adverse events were reported in 91% of patients, though most were either grade 1 or 2 events, such as chills, fever, nausea, and hypotension. 3 patients experienced grade 3 treatment-related adverse events, and 1 patient experienced a grade 4 event. Enrollment and dosing in all other clinical programs by Advaxis, the manufacturer of Axel, are unaffected. The NCCN now lists apalutamide as a Category 1 recommendation for the treatment of patients with non-metastatic castration-resistant prostate cancer. In treatment guidelines issued March 8, 2018, the NCCN included the next-generation androgen receptor inhibitor as a treatment option for patients with M0 disease, especially in those for whom prostate-specific antigen doubling time is less than 10 months. The FDA approved apalutamide in February 2018 for the treatment of patients with non-metastatic CRPC. The decision was based on the results from the international placebo-controlled randomized phase 3 Spartan trial, in which apalutamide reduced the risk of metastasis or death by 72% in patients with non-metastatic CRPC. The median metastasis-free survival was 40.5 months in the apalutamide arm versus 16.2 months in the placebo arm. The median time to metastasis was 40.5 months in the apalutamide arm, compared with the 16.6 months for placebo, and the median PFS was 40.5 months, compared with 14.7 months for placebo. This week, we sat down with Dr. Andrew Chi of NYU Langone Health to discuss the efficacy of checkpoint inhibition in glioblastoma.
Immune checkpoint inhibitors, inhibitors of PD-1, PD-L1, and CTLA-4 have now been in clinical trials for glioblastoma for a couple of years at least. They're in various stages of clinical development, phase 1 through phase 3, and also as monotherapy, sometimes in combination, and also in combination with other therapies, including chemotherapy and radiation, and potentially even other immune checkpoints. The early, very preliminary data from the very earliest trials indicated that potentially there were some patients who would benefit, some patients who responded. However, the first large randomized clinical trial of PD-1 inhibition monotherapy was recently reported. It was reported last year in 2017, and ultimately they did not see improved benefit, either survival or progression-free survival, over Avastin monotherapy, and this was with a PD-1 inhibitor. And overall, there were a very small percentage of patients that responded, and although it did seem like those percentage of patients that did respond was durable, it was a very small percentage. And what it really said to us as a field were a couple of things. And again, this was a trial that was done at the recurrent setting. Number one was perhaps the recurrent setting was not the right setting to be testing immunotherapy agents, or at least maybe just monotherapy of an immune checkpoint inhibitor. But the other thing is that there were a few responses, and what we don't understand completely yet is why those patients responded and the vast majority of patients did not. There are certainly intrinsic resistance mechanisms, and again, glioblastomas are amongst the most immune cold cancers that have been studied, so they have very low mutation burden relative to other cancers. They have low expression of PD-1 and PD-L1 relative to some other cancers, particularly ones that respond. And they have very little T-cell infiltrate, and the T-cells that have infiltrated into the tumor are often Tregs or immune suppressive T-cells, and other myeloid or immune cells that are in the tumor are often suppressive tumors, including microglia or macrophages, the tissue-resident macrophages, the neutrophils, and myeloid-derived suppressor cells. And so encompassing all of those factors in the tumor microenvironment really makes it unlikely that a PD-1 inhibitor, PD-L1 inhibitor, or any immune checkpoint inhibitor monotherapy to be successful against recurrent glioblastoma. What we learned from early experience with immune checkpoint inhibitors is likely that those drugs alone aren't enough and that we need combinations. So because there are not very many T cells in the tumor, we need a way to drive T cells into the tumor or increase the number of infiltrated T cells into the tumor. There's various ways to do that. Vaccination is a strategy whereby these tumor T cells can be, and particularly antigen-educated T cells can be driven into the tumor. And vaccination can be done through various strategies. One sort of in situ way to vaccinate a tumor might simply be just even radiation. So radiation has been studied as a method to incite the immune system within the tumor, increase antigen presentation, increase MHC expression, and also increase the diversity of the T cell receptor within the tumor. This might create a situation where more T cells have now arrived into the tumor and perhaps increase the efficacy of immune checkpoint inhibitors. So it's one example of a combination strategy that now many investigators are looking into. Many people are developing novel therapies for glioblastoma. and is to combine these immune checkpoint inhibitors with other strategies to drive T cells into the tumor.
That's all for today. Thank you for watching Enclave News Network. I'm Gina Columbus.